Hi, everybody. We'll go ahead and get started. Welcome to the IARS Virtual Education Webinar, Breathing Easy from Difficult Airway to Every Airway, Improving Safety of Airway Management in Pediatric Anesthesia. My name is Marilyn Stein. I'm a pediatric anesthesiologist at Boston Children's Hospital, and it's my great pleasure to get to moderate this webinar and to introduce our fantastic speakers today. But first, a few announcements to begin. This webinar has received no commercial support. Did you miss the 2025 annual meeting? On-demand recordings are available for purchase. For more information, visit the link on the screen. And don't forget to save the date for the 2026 annual meeting in Montreal, Canada. Late-breaking abstract submission is open. Submit your late-breaking abstract for the opportunity to present your research at the 2026 annual meeting, presented by IARS and SOCCA, May 1st to 3rd in Montreal, Canada. And for more information, please visit the link on the screen. For more exciting upcoming webinars, please visit iars.org/cme-webinars to register. And please submit questions via the Q&A button below. I'll be monitoring it throughout the talks today, and we'll have time for a nice discussion at the end. Our first speaker today will be Dr. Lina Sarimento. Dr. Sarimento is a Colombian anesthesiologist who's currently based in Mexico. She earned her medical degree and specialization in anesthesiology from Pontificia Universidad in Bogotá, Colombia, and completed her fellowship in pediatric anesthesiology at the National Institute of Pediatrics in Mexico City, where she currently works. Dr. Sarimento holds a master's degree in medical sciences from the National Autonomous University of Mexico and serves as a local investigator in Mexico for the Pediatric Difficult Intubation Registry. She'll be sharing findings from the PeDI Registry and how practice and outcomes have changed over time. Welcome, Dr. Sarmiento.
Thank you very much, Marilyn, for the kind introduction. Let me screen share. Okay, now you can see my screen. 1 second. Okay. So hello, everyone, and thank you so much for having me. It's an honor to share this webinar with all of you. Today, I will be talking about the PeDI Registry, the Pediatric Difficult Intubation Registry, and the lessons we've learned over the past 10 years. I'd like to start by disclosing that I have no conflicts of interest related to this presentation. And before diving into the lessons learned from the PeDI Registry, let's take a step back for a moment and talk about what the registry is and why it's so important. The PeDI Registry is a collaborative, multi-center international registry that collects data on children with difficult tracheal intubations. It is housed under the Society for Pediatric Anesthesia and allows us as researchers to analyze trends and outcomes in this very specific and high-risk population. We closed data entry in July 2025, and the registry now includes more than 9,000 cases, which will be preserved as a historical reference for future investigations. Importantly, our work didn't stop there. The PeDI Registry has now evolved into an ongoing collaborative research network focused on prospective airway studies and targeting specific research questions in pediatric airway management. So this slide shows the timeline of PeDI Registry publications, starting with the landmark article by Dr. Fiaggio. And here at number 14 is the article we'll be focusing today. As you can see, this has truly been a team effort with a meaningful impact on the quality of care for children with difficult airways. These publications cover a wide range of topics from basic face mask ventilation to advanced techniques such as hybrid intubation approaches. It's been an incredible, productive 10 years academically. And if you're an anesthesiologist who works with children, I strongly encourage you to read these studies. Understanding these findings can truly make a difference in clinical practice. So today I'll be highlighting key findings from this article, Airway Management in the Pediatric Difficult Intubation Registry, a propensity score match analysis of outcomes over time led by Dr. Mary Stein, and published in Clinical Medicine in February 2024. In this study, we wanted to evaluate whether the guidelines and educational efforts that follow the initial PeDI Registry report in 2016 actually changed practice, and more importantly, whether those changes improve outcomes for children. To answer that, we compared two cohorts, an early cohort from 2012 to 2015, and a more recent cohort from 2017 to 2023. So what did we find? First, the first attempt success rate was significantly higher in the current cohort. In other words, we were more often getting the tubing on the first try, which is a major win. Fewer attempts mean less trauma and less stress for everyone involved. Second, there were fewer overall intubations attempts and fewer attempts using direct laryngoscopy. So persistence with direct laryngoscopy also decreased significantly. And this suggests that the message is coming through. If direct laryngoscopy isn't working, it's time to move on to a different technique. Third, we saw a significant increase in the use of supplemental oxygen during intubation. In fact, patients in the current cohort were 3 times more likely to receive supplemental oxygen. And when I talk about oxygenation, I mean strategies like low flow nasal cannula during the intubation attempt, as shown in this video from my own clinical practice. You'll also notice that video laryngoscopy is being used as the first attempt device. Fourth, we observed a shift in ventilation strategies. There was an increased use of controlled ventilation with muscle relaxants, suggesting a move toward a more controlled approach to intubation in these challenging cases. And at the same time, the use of spontaneous ventilation decreased, possibly reflecting concerns about airway reactivity and loss of control during difficult intubation scenarios. Before discussing the most important outcome, it is important to clarify what we define as severe complications in the registry. These include severe airway trauma, pneumothorax, delayed recognition of esophageal intubation, cardiac arrest, aspiration, the need for a surgical airway, and death. So with that in mind, the most striking finding was that the rate of severe complications was nearly cut in half in the current cohort, with a significant reduction in cardiac arrest. So this clearly demonstrates that collaborative efforts, education, and changes in practice can have a real impact on patient safety. It is worth noting that overall complication rates were similar between the two groups. So what else changed? One major shift was the increased use of video laryngoscopy. The successful use of standard blade video laryngoscopes increased from just 5% in the early cohort to over 31% in the current cohort. We also looked at factors associated with severe complications, and these included the presence of airway and craniofacial abnormalities, higher ASA physical status, emergency procedures, persistence with direct laryngoscopy, cases in which anesthesia wasn't induced by the anesthesia team, and situations involving impossible ventilation. So where do we go from here? So education and improved access to video laryngoscopy have clearly contributed to better outcomes. However, despite these improvements, severe complications still occur more frequently in this population compared to the general pediatric population. Continued efforts are needed to limit direct laryngoscopy, ensure adequate oxygenation, and encourage early transition to advanced airway techniques. So far, I've shown how changes identified through the PeDI registry have improved outcomes, fewer attempts, better strategies, and fewer severe complications. But there is an important question we need to ask. Who is actually benefiting from these advances? Last month, we published a correspondence highlighting the challenges faced in the countries where my colleagues and I practice anesthesia, bringing visibility to the gap between global guidelines and local realities. PeDI data clearly show that changes in strategy, training, and technology improve safety in difficult pediatric intubation. Yet, the global majority of children undergo anesthesia in resource-limited environments. So future guidelines and research must therefore be inclusive, context-aware, and equity-driven. Our challenge moving forward is not only to generate high-quality evidence, but to ensure that this evidence can be implemented globally so that safer airway management is not a privilege, but a standard for every child. Okay, so that brings me to the end of my portion of the presentation. Thank you so much for your attention and for joining this webinar. I hope this overview of the evolution of pediatric difficult airway management has been informative. Thank you.
Thank you so much, Lina, for that excellent overview of the PeDI registry and your really important points highlighting the importance of evidence, but also recognizing global realities. Our next speaker is Dr. Vinicius Quintao. Dr. Quintao is a consultant pediatric anesthesiologist at Hospital das Clínicas Faculdade de Medicina, Universidade de São Paulo, Brazil. He serves as director of the Pediatric and Neonatal Anesthesia Fellowship Program. And Dr. Quintao also recently completed his PhD focused on long-term behavioral changes and epigenetic modifications in children who experience emergence delirium. Currently, he's a postdoctoral fellow leading the Latin American Surgical Outcomes Study in Pediatrics, LASOS-Peds, the first multi-center study to describe postoperative outcomes in children across Latin America. And he'll be sharing his work as leading LASOS-Peds today.
Thank you so much, Mary, for inviting me and also for organizing this amazing webinar. And also thank you, the International Anesthesia Research Society, for organizing this webinar. So as Mary introduced me, I'm Vinicius. I live in São Paulo, Brazil. And in this brief presentation, I will share the final, though still unprocessed, data from the LASOS-Peds study, the Latin America Surgical Outcomes Study in PEDS. So I have no conflicts of interest to disclose, and this is my institution here in São Paulo, Hospital das Clínicas, which is part of the University of São Paulo. This is our main campus. It includes 8 institutes plus the medical and nursing school. And within the campus, we have a fully dedicated Pediatric Institute. So Brazil is considered an upper middle income country by the World Bank, but it is still part of the broader low and middle income group. And even though Brazil is one of the world's 10 largest economies, income distribution is extremely uneven. And this inequality reflects what we see across much of South America and, of course, Latin America. Global surgery from this paper show that about 89% of all children under 19 live in low and middle income countries, and more than 67% of them either don't have access to safe surgery or receive it under very limited conditions. And even though most children live in low and middle income countries, less than 20% of the global surgical workforce, that includes anesthesia, is actually based in these regions, which helps us explain why so many children still lack access to safe surgery. About 80% of deaths from non-communicable diseases, many of which require surgical care, also occurs in these countries. And the last point on this slide is really striking. So for every child who faces a delay in basic necessary surgery, an average of 8.4 years of disability are added to their life. So this shows just how profound the impact of lack of surgery access can be for children. So the incidence of severe intraoperative adverse events is also much higher in low and middle income countries compared to the high income countries. In high income settings, the rates range from about 2.4 to 5.2%. And middle income countries like Brazil, it can reach around 12%. And in low income countries, the rates are even higher. So income level is clearly tied to major differences in access to safe surgical care. One of the first prospective studies to assess severe intraoperative adverse events, including airway complications, was conducted by our colleagues in South Africa. And this is a secondary analysis from the South Africa Surgical Outcomes Study. And this study revealed a higher incidence of airway complications, that we can see here, compared to high-income countries. The same research group, led by Professor Bruce Picard and Dr. Alexander Torborg, also from South Africa, extended this work to pediatric patients with the African Surgical Outcomes Study in Pediatrics. This study I'm showing here. The main results that was published in 2024 show that the most common postoperative complications in children undergo surgery in Africa were surgical infections, followed by postoperative bleeding. The study also reported a surgical mortality of 2.3%, which is 11 times higher than in high-income countries. They also published yet the postoperative complications, findings on intraoperative complications, including airway-related events, will be published probably this year. So, building on the work from our colleagues from Africa, Professor Bruce and Dr. Alexander Torborg, and with the valuable support of Smile Train, we launched the LASOS-Peds. So, but what is Latin America? So Latin America refers to the region where Romance languages, mainly Portuguese and Spanish, are predominant. So in Brazil, we speak Portuguese, but the majority of the other countries in Latin America speak Spanish. This term, Latin America, was first used in the United States to distinguish this region from US and Canada. And although there is no official definition, it generally includes countries in the North, Central, and South America, as well as the Caribbean. And again, why it's important to study perioperative outcomes in Latin America. So this region is known for having some of the greatest inequalities in access to healthcare worldwide. I live in São Paulo, as I said. São Paulo is the largest city in the Latin America, actually is the largest city in the Americas, with around 21 million people. And I can see these inequalities very clear here. In this photo, this photo is from São Paulo, from The Guardian, the journal The Guardian, the newspaper The Guardian. we see a luxury building standing side by side with a slam. So a striking image of inequality that we have here in our region. So now back to LASOS-Peds. So our primary goal was to determine the incidence of in-hospital postoperative complications within 30 days of surgery. As secondary objective, we aimed to assess the incidence of intraoperative adverse events, including airway complications. We conducted a 14-day multi-center prospective and pragmatic cohort study, including all consecutive patients under 18 years old, undergoing elective and no-elective surgeries or non-surgical procedures. Our primary outcome was a composite of postoperative complications, including surgical infection, pneumonia, postoperative bleeding, arrhythmia, and acute kidney injury. And as a secondary outcome, we also assessed intraoperative adverse events, including airway complications. So the recruitment for LASOS-Peds extended from December 2023 to February 2025. Patients were recruited from 149 hospitals across 13 countries in Latin America. The recruitment was completed with over 8,600 participants. The median age was 6.3 years, with the majority being male and classified as ASA status 1 or 2. In our cohort, the most common comorbidity we observed was congenital anomalies, and about 3.3% of children had an upper respiratory tract infection in the 2 weeks leading up to surgery, which is clinically relevant, especially for airway management and anesthetic risk. When you look at surgical severity, over half of procedures were considered mild and near 80% were elective, suggesting that overall, this was a relatively stable surgical population. The main driver for surgery in this group was also non-communicable diseases. These are our results, our primary outcome. Overall, when compared to the African cohort, we observed a higher rate of postoperative complications. This is concerning, finding that should prompt critical discussion and drive political action aiming to improve surgical care for our children here in Latin America. Looking more closely at the primary outcome data, we found that the leading causes of postoperative complications were quite similar to the African cohort. However, our cohort, the Latin America cohort, showed better surgical mortality outcomes when compared to the African cohort. Here is our secondary outcomes, specifically airway complications. So our numbers closely align with those of the South Africa cohort. We don't have the whole continent data yet. But when you compare especially the airway-related complications with another huge cohort, the Africa study, we observed significantly higher rates of airway complications comparing our data with the APRICO, which is an European data. So in conclusion, our findings show clear disparities in pediatric surgical outcomes across Latin America. Intraoperative events were much more common than in high-income countries. And for instance, cardiac arrest were especially frequent, 6 more times frequent compared to the high-income countries, intraoperative cardiac arrest. After surgery, almost 1 in 5 children had a complication, showing a substantial burden of morbidity. Mortality was also higher, about 3 times than expected benchmarkers. It was lower than we see in the Africa cohorts, but still higher compared to another cohort, the European cohort, the apricot study. So overall, results highlight an urgent need to improve surgical safety and care quality in our region. Looking more specifically at airway-related outcomes, so we found that the Latin America cohort actually had fewer complications compared to the South Africa group, which is orange. But compared to the European cohort, we see much higher rates of airway difficulty. So difficult intubations were 3 times more higher, and failed intubations were 2.5 times higher compared to the European cohort. And Lina also showed this piece that we just published in the British Journal of Anesthesia. And here I have some key challenges. So first, many clinicians in our region still don't get formal training in pediatric airway management, and this is essential for safety. We also don't have enough specialized pediatric centers, so access to advanced care is limited in many areas. Most of the airway algorithms we use were created in high-income countries, and they don't always fit the reality of low and middle-income settings. Cognitive aids like checklists and protocols are also hard to find in local languages, especially Portuguese, which makes everyday use very difficult for us. And finally, many hospitals still lack basic airway equipment. So this concludes my presentation. We are still working with the LASOS-Peds data, focusing on identifying risk factors for both postoperative and intraoperative complications, and that includes airway management. We hope to publish the complete data very soon. Thank you so much for your attention.
Thank you so much, Vinicius, for that fantastic overview and for all of your work leading LASOS-Peds. For all our participants, please put questions for our speakers in the chat. We'll have an opportunity for discussion after our next speaker, who's Dr. Annery Garcia Marcinkiewicz. Dr. Garcia Marcinkiewicz is an associate professor of anesthesiology and critical care at the Children's Hospital of Philadelphia, where he's also an associate division chief for general anesthesiology and director of the difficult airway program. Dr. Garcia Marcinkiewicz is passionate about improving the safety of pediatric airway management and airway education. She's the site PI for the Pediatric Difficult Intubation Registry at CHOP and enjoys engaging other interested sites in performing airway research. Dr. Garcia Marcinkiewicz serves on the board of Women in Anesthesiology and is the current president. This afternoon, she'll be speaking on difficult mass ventilation in the PeDI Registry.
Thank you so much. I am going to share my slides. And I think we could see my screen, and we'll go to play from start. Okay, I think we can see from the beginning. Perfect, thank you. Well, thank you everybody for sharing this time this afternoon to talk about what we've learned in pediatric difficult airway management. And as Dr. Stein said, I'm going to be focusing mostly on difficult mask ventilation. I have nothing to disclose in relation to this presentation. And so whether we're taking care of a patient who has what seems like a very reassuring airway, like this baby, okay, certainly, this baby comes with the challenges of managing an infant airway, but overall, craniofacially, at least anatomically, we see, this baby probably will have a relatively reassuring airway. Or whether we're taking care of a patient who has an airway that looks like this, an airway that should at least make you pause, might raise some red flags, might have you ask for additional team members to come help. It boils down to the basics. Okay, a lot of the complicated things that we do comes down to some basic principles that we, alternate, that we apply some other, other techniques to over and over. And I'm extremely grateful for all the work and all the team effort that has been done by the PeDI Registry Collaborative Group in helping us improve some of our safety practices, as you heard in the previous two presentations. So let's go to the beginning. Okay, we have this patient. This patient needs their airway managed. Maybe this patient does not have a tracheal tube in place. Maybe there's an opportunity to provide some mask ventilation for the patient, or maybe you're taking care of a healthy child who is coming to you for elective surgery and you're beginning your anesthetic with an inhalation induction. Okay, so mask ventilation, what do we know about in children? So here are some of the objectives that I have for the end of this presentation. We'll touch upon some of the specific risk factors in children that increase complications. We'll talk about what we've learned about difficult mask ventilation in children and how common it is, some of the factors that increase that risk, and hopefully be able to leave here with formulation of plans that can improve how we mask ventilate. So here's the task that we're typically faced with. We need to safely provide sedation and induce anesthesia in this infant. We need to mask ventilate properly, a big key thing. We need to intubate seamlessly, do it all with style, like nothing ever happened, all while likely teaching somebody, and extubate at the end. So all of that in one shot. So why is it that the stakes are so high? Why is it that, clinicians that might not take care of children very often feel understandably, challenged when taking care of a child again? And it comes to, again, back to the basics, right? So you need to understand the airways that you're taking care of. You need to, particularly in children, particularly in children, understand what are some of the basic anatomic differences compared to adults. What do we expect so that we can locate that airway and find what we need to see? So, some basic things that, people in this forum already know, things like, well, the airway is a little bit higher, right? We have a tongue that may be normal for an infant, but is disproportionately large compared to the rest of the oropharynx. So, what just happened? Excuse me. Let me go back to that presentation. My apologies. So upon a child having sedation or anesthesia induced, they go into a natural state of flexion, which leads to airway collapse, right? And then we have some differences between where the glottis and epiglottis is located in an adult and in an infant, right? We see a pretty parallel relationship. You see epiglottis, you see glottis in the adult, but we have more of an acute angle in an infant, right? And so appreciating these differences and kind of starting off already expecting these anatomical differences is what's going to help prepare us to have, success, hopefully on the first attempt. And then there's the physiologic vulnerabilities that we have in children. So they consume more oxygen. That is one big thing. We run out of time. You might know what you're looking for, but if you don't find it quickly enough, you'll run out of time. They consume 6 to 8 mLs per kilo per minute compared to a healthy adult who might consume 3 mLs per kilo per minute. They have lower functional residual capacity, rapidly can desaturate, and they also have a more profound vagal tone. So some of the manipulations that we're used to doing with adult airway management, a child can, have a vagal response and become bradycardic to some of that. So very important to, understand this right off the bat so that this doesn't happen. Multiple intubation attempts in a child. And as you heard Dr. Sarimento talk about, the more attempts, the more complications, okay? And the odds of having complications increases with each attempt, 1.5 times per each attempt, okay? Particularly more than 2 attempts significantly increases complications. And then we have edema in these tiny little airways. So if you look at the adult airway, about an 8 millimeter airway compared to a 4 millimeter airway in an infant, Look at what 1 millimeter of edema does. So now you've had several attempts, maybe have repeated the same technique over and over, and now someone that might have more experience comes in and wants to, do something different, but now it becomes progressively harder, right? And the closing volume is larger. So now it takes more pressure to open up those airways, and it's just a vicious pathway. Adverse airway outcomes are high in children. They're high even in the perioperative environment. So, again, it depends on where you are and what your practice is. But we see some complication rates, as high as like 20% in some of the intensive care unit environments. Complication rates even as high as 40% in some of the emergency department settings. In the perioperative space, 3 to 20%. So still pretty high. Still more work for us to do to improve the care for our patients. And so what if we could predict these things before they happen? What if we could, have a way to, have a risk assessment and a better appreciation of the danger that our patients are in so that we can prepare for this moment? Difficult ventilation. It is a terrible situation to be in, right? And we are often caught in a situation of difficult intubation. And now when we have the combination of the two, it is a very stressful circumstance. And what do we know about difficult ventilation? Well, from adult data, we know things like, certain anatomical features like not having teeth, having a beard, obviously having tumors or other blockage of the upper airway, foreign bodies, having radiation to the neck. And some of those things do apply in our younger patients, such as like radiation to the neck, having, foreign bodies, etc. But most of our kiddos, don't really have some of those factors. So what else did we learn about difficult mask ventilation in adults? The incidence is about 1.4%. Maybe impossible mask ventilation is, thankfully very infrequent, somewhere around 0.15%, maybe a little higher in other settings. But again, some of these features don't apply to the younger patients that we have. So I think, as we discussed in a previous slide, the anatomic differences in a child are different than an adult, right? And so there are some features that might particularly put our younger patients at risk. And in fact, I wish I could have the Pediatric Difficult Ventilation Registry because, like I said, I think that is an even worse problem than intubation. So we wanted to see what was out there, as far as difficult mask ventilation data in children. And apricot was mentioned. We learned a lot from the apricot study, and we learned that perhaps the incidence of difficult mask ventilation in children is about 0.88%. Then a Canadian study showed that maybe it's around 6.6%, so somewhere in between there. So then we set out to see what we can learn from the PeDI registry regarding difficult or impossible face mask ventilation in children who are difficult to intubate by definition. And so for this, we had, at the time of the study, around 6,000 encounters in the PeDI registry. And then they were broken up into patients who were easy to mask ventilate, those who were difficult to mask ventilate, and impossible mask ventilation. And we noticed that a lot of the patients had accompanying syndromes. Many of the patients were taken care of with spontaneous ventilation. And that, generally speaking, this occurred. Difficult or impossible face mask ventilation was encountered around 9% of the time. So higher, right, than some of the data that we had in the past. And some of the syndromes that are specifically associated with difficult or impossible face mask ventilation, you see here, Pierre-Robin, Treacher-Collins. Being an infant increases your risk, of course. And then extremes of weight, less than the 5th percentile, greater than the 95th percentile. Okay, and anesthetic depth, and we'll get into that. Treacher-Collins, out of all the syndromes, was independently associated with a higher risk of difficult or impossible face mask ventilation. So here you see a summary of those specific associations that we found. Also, glossoptosis and limited mouth opening. Again, so some things that are consistent with adults, but some things that are unique to children that were worth highlighting. Irrespective, complications are threefold higher, right? If you are difficult to intubate and difficult to ventilate, of course, you are going to have a much greater odds of having some of the complications that we see in the registry. And I show this baby here because, here you see, some CPAP being provided to this baby and some intubation attempts that have occurred in this patient, and anesthetic depth, the patient being as reactive as they are during intubation attempts, right? And so understandably, we don't want to, burn the bridge and provide, too much sedation, to any patient, right? And many times we are trying to fine-tune a spontaneous ventilation technique for the reasons that we want to keep this airway patent, because perhaps we are, using the patient's own inherent airway tone to keep their airway open, right? But then we might underdo it and not provide sufficient anesthetic depth to get the right intubation conditions. And then some of the issues happen as a relation to this. So why don't we just paralyze everybody? Why don't we just provide neuromuscular blocking agents to all of our little patients? And it's thankfully not because we're frequently encountering mediastinal masses or tumors in the airway, because thankfully those things are, infrequent in our patients, not because of myalgias or thankfully anaphylaxis, right? But because of this, right? Again, perhaps the patient has a condition in which we notice that there's some craniofacial differences, some anatomic variations, right? And even smaller mandible, right? And more micrognathia or severe retrognathia. And it is that patient's inherent tone that is keeping their airway open. So we want to be very careful when we're providing neuromuscular blockade, right? That is the traditional teaching. So a previous PeDI registry study, we actually asked the question, is there a relationship between initial ventilation technique during endotracheal intubation, okay, for that initial attempt, and complications in the PeDI registry? And at the time, we had over 1,700 encounters, and we broke these down to spontaneous ventilation, controlled ventilation with muscle relaxant, and controlled ventilation without muscle relaxant. And a reminder of the complications that we're looking at, broken down into non-severe complications versus severe complications. And you can see non-severe complications, things like hypoxemia and laryngospasm, and immediate recognition of esophageal intubation, versus severe complications are more gravid things like severe airway trauma, delayed recognition of esophageal intubation, cardiac arrest, death. And we found that spontaneous ventilation is associated with more complications compared to the other two techniques, compared to controlled with muscle relaxant and controlled without muscle relaxant. And you see here, though, that these two, controlled with muscle relaxant, controlled without, have lower complication rates, but pretty similarly lower complication rates compared to spontaneous ventilation. So then the next question was, well, why? What is happening? Why is spontaneous ventilation associated with more complications? And we were able to capture, not surprisingly, that spontaneously ventilating patients have increased airway reactivity compared to those that are paralyzed or provided controlled ventilation without muscle relaxant, right? So those patients with controlled ventilation without muscle relaxant, that was an important highlight of investigating this work, because it told us, well, it's not necessarily the muscle relaxant. Yeah, in many cases it is that, it's helpful to provide, the right intubation conditions, but it can also be accomplished with sufficient anesthetic depth, perhaps a little, greater anesthetic depth than the patients who are spontaneously ventilating are receiving. And naturally, patients with airway reactivity then have more complications. So this is kind of the mental model of what is happening. Spontaneous ventilation is associated with reduced anesthetic depth, which is increasing airway reactivity, which is driving the complications. So anesthetic depth is mediating the relationship between spontaneous ventilation and between ventilation technique and complications. Okay, so very important. It's not that spontaneous ventilation is causing complications. It is associated with more complications because there's a mediator in between, and that is reduced anesthetic depth. So this is a quality improvement issue. Again, the PeDI Registry with over 44 sites around the world, and we are seeing this. This is happening to all of us, right? Again, we're working really hard to keep that spontaneous ventilation going and not overdo it and keep that patient's inherent airway tone, understandably. But then we have reduced anesthetic depth, and then this is driving airway reactivity. So we need to, do better here. This is, again, a quality improvement project. And what else we learned from that PeDI mass study? Well, what happens when you do give neuromuscular blocking agents to those patients who are either difficult or impossible to ventilate? Well, this was an interesting one because what we see here is, well, generally speaking, you don't have that much to lose, right? Because providing neuromuscular blockade either improved or didn't change the quality of mask ventilation. In very few cases did it worsen, right? So if you're in that situation, you can't intubate, you can't ventilate, then you don't have that much to lose if you paralyze, right? Another interesting thing, well, we learned that when people encountered a situation in which they had difficult or impossible face mask ventilation, they reached for a supraglottic airway less than 35% of the time. Less than 35% of the time, right? And this is something that we know. We know to do this from day one, right? Supraglottic airway is part of the difficult airway algorithm. So why? What is it that's happening? It's almost like we get caught off guard, right?
The window,
Like
let me know everything's
in this situation.
fine.
This poor child got caught off guard, right? And what happens is when we encounter an airway that looks like this, like for example, this patient with hemifacial microsomia, right? And we have difficulty intubating this patient and difficulty ventilating this patient, the cognitive overload that we have is so high in situations like that that we forget our own name, right? So we might even forget about a supraglottic airway. So don't forget that it's out there, and it can be a very important bridge to ventilation and intubation, right? We don't have to, if we can't intubate, we don't have to repeatedly go back to trying to mask ventilate. We can bridge with a supraglottic airway, buy ourselves some time, increase our anesthetic depth, or provide neuromuscular blockade, get that patient recruited and oxygenated, right? And then move on and try a different technique, have more help come in, right? Which we should call from in the beginning, and have someone else do something different. So back to the basics, right? Ask yourself, when thinking of providing neuromuscular blockade to a patient, do I expect ventilation to be difficult? Is access to the oral cavity or upper airway blocked by something, right? And generally, if the answer to these two things are no, many of your patients are safe to receive neuromuscular blocking agents up front. Because when we see these patients, we need to have a plan, right? We need to make sure that we are being very meticulous about every step and realize that, a priority is oxygenation. The most important thing we do for our patients is keeping them alive and well and oxygenated. And in this study by Dr. Hodgson and colleagues, they randomized neonates to either oxygenation, conventional oxygenation via nasal cannula, or no oxygenation during intubation. And they did this very pragmatically. Some patients, were intubated with direct laryngoscopy, video laryngoscopy. Some patients received neuromuscular blockade. Some patients didn't, so on and so forth. And, this is a video of their trial, the SHINE trial, submitted by the authors to the New England Journal of Medicine. And on the right, top right, you see the patient's oxygen saturation, 98% right there. And you see this baby who requires intubation. Direct laryngoscopy is actually being used. And although this may not seem like a lot of time is passing in someone who consumes a lot of oxygen, like we discussed earlier. And you can see the patient is still doing okay, 99, 98%. Look, this patient is receiving oxygen via nasal cannula, and this very basic little element is buying us so much time, right? And there's a lot going on here. And eventually this patient gets intubated and does well. But look at what the power of peri-intubation oxygenation provided in someone who consumes so much oxygen. And so we can use things all around us to help us buy time. So for example, if you're doing a nasal fiber optic intubation or a fiber optic intubation in a baby, right, you can use the things around you, like your circuit, a nasopharyngeal airway, modify it by putting the 50 millimeter connector of an endotracheal tube, connect those two, and provide some oxygenation on the other nostril if you're going to go in through here to do your fiber optic. This will buy you time. And down here, for some of our ENT procedures, having this form of oxygenation will get you more time. When we do fiber optic intubation via a supraglottic airway, right? Again, we're not only, getting the procedure and facilitating maybe, movement of some tissues that might get in the way, we are also ventilating the patient. Because this could be the airway that you might be encountering. And this is a patient who is not in laryngospasm and their cords are actually open, but this is how air enters them as they are awake and, trying to speak and interact in the world. And this is not anaphylaxis. This is a patient with a mucopolysaccharidosis. And this is the structure of their airway. So we need to plan, we need to ask for help early, and we need to use all of the things that we have, all of the ways that we can optimize airway management safety during that initial intubation attempt and all the others. So from this talk, I hope that you can appreciate that infants are at higher risk of difficult or impossible face mask ventilation. Patients who are at extremes of weight, so less than the 5th percentile, greater than the 95th percentile, are also at increased risk, and other craniofacial factors, increase the risk for these patients. Anesthetic depth matters. So whether you are going to provide neuromuscular blocking agents up front or not, please ensure that your anesthetic depth is appropriate for every step of your airway manipulation encounter. And that anesthetic depth can vary, can be a very dynamic thing, depending on where you are in the airway management course. So the anesthetic depth that you need to place a nasopharyngeal airway is different than the anesthetic depth you need to be able to drive a fiber optic scope, which may be different than the anesthetic depth you need to get that fiber optic scope to go through the vocal cords. So pay close attention to that. Build conduits of oxygenation, right? So every step of the way, as we're changing things, right, make sure that this patient who's having an intubation encounter that can take longer and can have more complications has different ways of you keeping them well and well oxygenated. And don't forget about your supraglottic airways. Thank you so much for your time, and I look forward to our discussion.
Annery, Lina, Vinicius, thank you all so much for those really fantastic presentations. We've gotten some really great questions into the Q&A, but I'm going to take the prerogative as the moderator and ask you my question first. So I know that in addition to all of your really fantastic academic airway work, you all have important roles as educators. And I'm curious, when you're in the OR with a learner, somebody who's learning to intubate a baby for the first time, what do you do to help them? What do you want them to take away for their future practice? And how do you keep your own stress level low?
Who wants to go first? I think for me, it's, we are considered a low middle income country. So we don't have that many spaces for doing practicing simulation. We don't have that in our career. So for us, we're practicing with child, and it's hard for us. So I try to maintain calm, but I've learned a lot from the PeDI registry. I always use low flow nasal cannula. I try to use video laryngoscope, I always tell them, you're going to try just one attempt and then I'll go do the second one. So I try to keep all those things that I've learned during these years and try to teach them and spread the word. So I think simulation will help a lot, and we need more airway workshops to learn. And for this part of America, we need that. So that's how we are doing here back in, unless in Mexico.
Oh, great points. Thank you.
Well, I use the last slide of Annery. So I apply the last slide of Annery. So death matters. Try to use neuromuscular blocks because some colleagues are still not using them in all cases. And also apneic oxygenation. So I think apneic oxygenation is very well tool to use for those cases. So here in our center, as Lina said, we're also a low and middle income country. But we do have access to video laryngoscope, etc. And we try to use, I also learned from the PeDI Registry, I try to use in all cases in children under 1 year age and neonates. And try to become as much as I can. But my main goal is to keep the child oxygenated, not to intubate. So if I keep the child oxygenated, I'm good.
That's such an important point. Thank you.
Yeah, I think talking through the situation with our learners is very important. I think when it's possible to practice with even some low fidelity simulation, so a mannequin to kind of like, talk through the steps and rehearse the steps is very helpful. And I think also having an appreciation for where the difficulty of that difficult airway lives, right? It's not just, oh, difficult airway. We have all these tools and things that we can use, but really helping your learner identify where is the difficulty of this difficult airway? Is it an anatomic issue? And if so, where in the line and path of their anatomy do I expect to encounter that difficulty? And maybe it's not, maybe it's a physiologic issue. So what is it? And again, how will that impact my airway management? Perhaps it's a combination of both. So really helping to kind of grasp that understanding so that then it's not like we're memorizing steps. We're kind of gearing into the airway gears us into the next direction that needs to be taken to then overcome the next challenge.
Yeah, definitely. A few questions from our participants too, a couple on medication. So how is dexmedetomidine changing or getting involved in your airway management practice?
I think it's a very helpful adjunct, and I will use it pretty frequently when I'm trying to fine-tune my anesthetic depth when keeping spontaneous ventilation. It might not be the sole agent that I use, but it certainly helps to provide other opioid-sparing techniques and to kind of keep that patient breathing.
Yeah, I think it's a great med, and we're using that much for pre-med for the pre-medication. We're using nasal dexmedetomidine, and it works really good for us. So 1 to 2 mics per kilogram, and it helps us to reduce all other medications.
Yes, of course. I also use to maintain spontaneous ventilation if I want to intubate or to manipulate the airway under spontaneous ventilation. And I think it's a very important drug medication with children with obstructed sleep apnea. If you intend to extubate this kid under deep anesthesia. So I'm very comfortable to do that if I use dexmedetomidine.
Yeah, it's definitely changed my practice as well. Annery, there are some questions about, and I know you addressed this already, but LMA for rescue in the difficult mask ventilation cases. Can you talk a little bit about how you help people to overcome that hesitancy to use it, where we're seeing only a third using it? And then also thoughts on using a nasal airway, maybe in a case where there's not even enough space for an LMA to fit.
Thank you. Yeah, I'll address the last part first. So a nasal airway, like a NP airway, a modified nasopharyngeal airway, I will turn to that many times. Sometimes we have a patient who has, you know, many craniofacial differences and, facial asymmetry, hemifacial microsomia, and there isn't even a way to really grasp to be able to provide face mask ventilation. And really then we're kind of mask ventilating with a modified NP airway. That might be the conduit of oxygenation. And this is why I like the term kind of building conduits of oxygenation, because as you're moving along your airway course, you might not be able to keep your hand on the face. And now you have to find another way to buy time in something that, might have a bit more of a tortuous course and might take longer, right? A situation like that. So I do love modified NP airways for that reason in those circumstances. And then as far as reminders, cognitive aids certainly help. And also when, walking into a situation in which a colleague is struggling, just hold up the LMA and suggest it and pass it. And go ahead and say, hey, look, before this intubation attempt, which was a very good one, and we used, we might have even used video laryngoscopy for, it did not work. It was not successful. So rather than going back to the mask, let's just place this LMA in and just kind of let's relax the situation a little bit so we could all breathe. And then we all realize, okay, hey, ooh, we calm down a little bit and gives us some thinking space for the next move.
There's a question about CME in the Q&A, and we are getting that information for you. And then another question on stylets or guides or bougies, and if they make a difference in outcomes in the PeDI registry or in the LASOS study. I know for the PeDI registry, and you guys can correct me, the data is in there, but I don't think anybody's looked specifically at that.
I asked the manager for the PeDI registry, the amazing Paula, who how many intubations that we have used stylet or stylet specifically, and we only have a few use stylet, but I don't know. Maybe we can try to look at the PeDI registry for bougie and also compare with stylet. So it's a very good question for another study proposal to using the PeDI registry.
I want to thank everybody for joining us today, and I really huge thank you to our amazing panelists. I learn so much every time I hear you speak, and I really appreciate you guys sharing your wisdom and knowledge with us all today. Thank you.
Thank you.
Thank you so much.
Thank you very much.